Interim Medical Director for the Health Corporation of America Midwest Division in Kansas City, Missouri, where he oversees pathology and the laboratory services for 7 hospitals and 8 ambulatory surgery centers. Prior to joining HCA, Dr. Hameed spent 7 years at the Vanderbilt University Medical Center, where he was professor and vice chair of pathology, microbiology, and immunology, executive medical director, and division director of anatomic pathology. Dr. Hameed has studied in both the United States and abroad. He has published many peer-reviewed articles as well as many books and book chapters. Often a sought-after speaker, Dr. Hameed strongly believes that outstanding pathology and laboratory services are key to the excellent patient care, and this principle continues to guide his clinical research and educational activities.
Well, welcome, Dr. Hameed. We are so excited to have you today, and what an awesome bio. I mean, all the publications and the writings and being a professor and going to various seminars and speaking engagements. Do you even have time to breathe?
Thank you. Well, thank you for inviting me today to talk about pathology and pathologist and cancer and breast cancer. I really appreciate the opportunity to talk to you. And obviously, you have done quite a bit also to further visualize, cancer and breast cancers and impact on populations and individuals. So I'm really excited to be talking to you today.
Well, thank you. Yes, because we had our first meeting back in 2019, and we'll show a little bit of that a little later on. So right. For our listening audience, I just want them to know that they are in for a treat and for a host of wholesome information that you just couldn't get anywhere else. So I am so excited. So I want to ask this question. Dr. Hameed, what is a pathologist and the work of a pathologist?
It's a great question, and I think comes to mind, how much time do we have? So I'll try to be brief. So, briefly, a pathologist is a highly specialized MD or DO physician whose primary area of expertise is the study of organs, tissues, cells, and body fluids. So that's what we do. Now, what's the purpose of this study and evaluation? So primarily is first for the diagnosis of primary and secondary diseases involving this examined material. And this could be, like I said, could be a blood sample, and it's a new diagnosis of a specific type of anemia or diagnosis of leukemia. So that's something that pathologists would detect through evaluation of peripheral blood. Also, we evaluate a lot of biopsies, whether that is a breast biopsy, a biopsy obtained by endoscopy through, a GI, gastrointestinal biopsy from the stomach or colon, to as part of screening, what have you. And also, we evaluate tissue removed doing surgery. And again, the primary purpose of that is to diagnose primary and secondary diseases involving these tissues. Mm-hmm. Now, as I've alluded to, this often involves a determination of malignancy or not. So that's often a question that comes up. Is it this, what we're looking at, this process, is it a malignant process or is it not? And if it's malignant, it's really the type and nature of that malignancy that pathologists are really trained to evaluate and do. And that, the key aspect of that, that determines subsequent management and therapy following the diagnosis. So it's very different. Obviously the big question is, is it benign or is it malignant, right? That's a bigger question. But even when malignancy is determined, then the type and nature, and there's a lot of details that go into that to really determine outcome. Okay. The other thing, if I may, the other thing obviously pathologists also do. So all of what I've talked about previously is usually evaluating tissue and blood fluid, body fluids from living patients. Pathologists are also kind of like the cornerstone for determining causes of death, whether that's medical or forensic. So that's also part of pathologists, and they are usually most pathologists are trained. Almost all pathologists are trained to do perform autopsies, and of course, forensic pathologists actually have additional training to do that. And part of all this process, so that's talking about individual patients, but then pathologists are responsibilities really include the overall management of hospital clinical labs to ensure the highest quality. So as I'm also a medical director as a pathologist, so you are my patient, and I care that you get the best quality of clinical care, but part of my job also ensure that all patients who are where their material is evaluated in the lab get the highest quality. So that's pathologists are kind of, when they are medical directors, they oversee that aspect as well. And of course, we pretty much examine, evaluate, interpret, and are consulted on a wide myriad of different lab tests. So again, somebody might have a clinician might have a question about a result, then they would consult the pathologist and go on, so on.
Okay, so then you help with the cause and the effects of the disease and the behaviors of the disease, as well as provide the information to doctors so that they will know what's the best treatment for the patient.
Correct.
Awesome.
That's correct.
Awesome.
Yeah.
So as a pathologist, and I heard you talk about biopsies and getting the pathologies, how do you get the biopsy or surgically remove cancer tissues? And after receiving the tissues, what are you looking for? I know you said some are benign or malignant, but what are you looking for? Take us through a brief process of that.
Sure. Great question. So usually samples are obtained, either in doctor's clinics. Let's say somebody gets a skin biopsy punch, that could be in a doctor clinic. Sometimes it's in radiology, under radiology guidance. For example, a breast biopsy usually done under radiology guidance, and then specimens can be come out in the operating room with when patients are under anesthesia. So all of these are then sent with appropriate patient identifiers. One of the things we're really careful about in the lab, we get a lot of specimens, so critically that kind of transfer of specimens and requisitions, and we always look for to ensure patient identity. So that's the key thing, and that gets to the lab, and at the lab they're accessioned in the sense that so the specimens are registered, just like a patient is registered. Then subsequently his or her specimens are registered in the lab, and with a unique number, again a unique identifier, and they are again, we're talking primarily tissues and cells, and these are evaluated first by naked eye, and kind of like described by naked eye. There are a lot of features that are evident, or a lot of disease really evident by naked eye. And then depending on the specimen, it might be kind of the periphery would be inked with different colors. So as we'll come to discuss in your situation, when there is a malignancy and it's an excision, we want to determine how far the tumor is from margin. So that's to help with that up front, we actually ink the specimens so we can identify the inks on the margin. Then specimens are kind of serially sectioned, cut. Often if I kind of like more in a systematic way, like a bread loaf, you go through systematically to look at lesions, identify them, describe them. And a key thing is really sampling of the tissue. So, we get variably sized specimens. When we get a small biopsy, a GI biopsy, that's entirely submitted for pathologic examination. But as specimens get bigger, it becomes more difficult. So often sampling is what we do, and a key thing is you sample the abnormal areas. So kind of like that visual inspection up front will sample the tissue for microscopic examination.
Mm.
So after a specimen comes in, multiple sections are taken in what we call the gross room, because that's grossing in the specimens. And they are put in special cassettes, plastic cassettes, containers, and then is submitted to the lab, where they undergo kind of different processing steps. So eventually that organ or tissue that was excised eventually shows up on a slide. Okay.
Okay.
And then that slide is, evaluated microscopically to then determine the what's going on and what's the pathology. That information, and of course, sometimes we do additional testing to determine the diagnosis up front, and we might consult with others. Eventually, that information gets transcribed into a pathology report and gets into the medical record, with or without a discussion also directly with the rest of the clinical team regarding the diagnosis.
Wow, there's a lot that goes into it.
Wow.
Yeah.
My goodness.
Should an individual get a copy of his or her pathology report, and why would they need to have it?
That's a great question. Yeah, I believe that, I think especially in this day and age, I grew up in a time where, we were, or these physicians were very protective of patients. He or she could have cancer and nobody tells them, right?
Yeah.
I think this is long gone. I think patients are very much involved in their disease, and really everything in medicine now is really designed around the patient, because he or she is the hub and everything revolves around them. So I think it's very critical that patients get a copy of their pathology report. And in fact, I think there are laws now that actually require it. So yes, so there's recently there's something related to patient portability acts and also patient information that require pathology lab results to be released to patients. And I think usually there is a gap. It's not immediate, and that gap is usually to allow the clinicians, pathologists to discuss the findings with the patients, because again, somebody might get a pathology report. It's very long. It's not detailed, what have you. And I think it helps that there's a prior discussion. So, but that being said, I think it's very critical that patients get that report, because they need to be informed about their disease process. And pathology, like I mentioned earlier, is a key aspect that determines all subsequent follow-up. So they should definitely get that report and have it, have a standardized and potentially use it to ask questions as well.
Yeah. Thank you. So what are some of the common, I'm going to use my definition now of pathology. What are some of the common causes, effects, and behaviors of breast cancer pathologies found in women and in men? What are some of the common pathologies that you find?
So again, to repeat the question, you said common pathologic types, or?
Yes. And breast cancer in women and,
so I think,
and men.
Yeah. So interestingly, there's a lot of similarities between breast cancer in men and women. Very similar in a lot of aspects. And almost all the types of breast cancer that happen in women happen in men. There is one type that's much less frequent, and people argue that doesn't happen, is what's called invasive lobular carcinoma. So that the lobular comes from kind of like the breast lobules. So what's different between physiologic breasts in men and women is that they are women have additional growth around puberty and results in growth of the mammary lobules, which are the functional units that produce milk.
Mhm.
In men, that doesn't happen.
Mhm.
So kind of like a cancer that's kind of arising from that component is predominantly seen in women. Other than that, I think it's very similar all across. Now, yeah. So and that is a histologic type. So that's something we see under the microscope. There are other things related to that. As you know, and you're aware as well, when we talk about types of breast cancer, and how we might classify it, histology is only one aspect of it. There is classification based on hormone receptor status and HER2. So there are other things that go into that mix. But without going into too much details, in a way, breast cancer in women and men are very much different. Obviously, the incidence is much higher in women, and that has to do, if we get into that, obviously to do with some risk factors, and it's really related to, because it's very hormonally dependent tumor. So that's obviously, and it's estrogen, and that's why women are more susceptible.
Yeah. I didn't know that there was that much of a similarity. So that's interesting to know.
Yeah, it really is.
So, okay, Dr. Hameed, I have heard that cancer, breast cancer, has a high level of protein. And I'm asking for the audience. So if breast cancer or cancer tumors have a high level of protein, is it the same types of protein found in foods, milks, or soy? Or can foods even cause cancer?
So I was thinking about that question, and protein is very not specific, right? So protein is present in all cells, benign, malignant, right? And and without getting into a specific protein type, I can't tell you what that is. But that being said, when you talk about diets and impact of, on impact related to breast cancer, there has been a lot of studies about potential diets that might be related to breast cancer, but nothing really has come out that's consistent. I think the most consistent thing that has come out is really that breast cancer is there's a higher incidence in with obesity and decreased exercise, and the physiological explanation or the reason behind that is really relates to what I mentioned earlier, estrogen. So basically, adipose tissue, fat, really is a site for formation of like extra ovarian production of estrogen. So obesity leads to higher level of estrogen production. So that could be related, because a higher estrogen level, we know it's related to breast cancer as a potential cause. So that might be the relationship with obesity and decreased activity.
Wow.
But specific diets per se, I think there's no really a good relationship, and I'm not sure of a specific protein that you can find in breast cancer that's elsewhere.
So that means not everybody, but a lot of us with this, what they call it, this middle section that's kind of protruding a lot. Is that a type of obesity that needs to be checked and worked on?
Well, I think, remember, I think it's, it's not, it doesn't mean that somebody will get cancer because he or she is a pound over or 2 pounds over or what have you. I think it just, when you look at populations per se, people who are, have obesity have a higher prevalence of breast cancer than people who don't. So it doesn't really, it's not like when we talk about, if you talk about familial causes and what have you, and so having a particular gene abnormality is associated with a higher risk for that particular individual. It's it's more, when you look at these population studies, I think it's more of an association, but not always, also like causation.
I see. Okay, thank you.
And I think I gave you an example of the causation here, I'm sorry, is because we think there is an explanation to, for that association, which is the conversion, additional estrogen in the adipocytes.
Sure. Now, Dr. Hameed, when I had my lymph nodes removed, I was, wondering, why do lymph nodes have to be taken from the breast, and what do these cells tell you? I mean, not that they talk or anything, but what do you find?
Well, believe me, sometimes I believe they do talk to me.
I guess if you worked with
we try to, when somebody's involved in with their trade, I think I want them to talk to me and tell me what's going on. So, joking aside, I think so. Historically, and you go back, turn of the 20th century, in the late 1800s and early 1900s, removal of lymph nodes as part of, treatment of breast cancer or other cancers were, thought of as a therapy, right? So we're removing the cancer and we remove the lymph nodes because there are nodes in the cancer. What we've recognized and is proven today, I think when really the surgical removal is primarily used when the cancer is organ confined, okay? And that's when we removed it. Once it might have spread to lymph nodes or elsewhere, it's kind of like evaded the primary site, and it's more a systemic illness as opposed to a surgically resectable disease. So what used to be, we used to remove the lymph nodes. Okay, we want to take any site of possible cancer. What has happened today is actually we are evaluating these lymph nodes to better determine the stage of the disease. So, because we know treatment of localized breast cancer is going to be different from non-localized breast cancer. So evaluating a lymph node, and often, like I said, it used to be multiple lymph nodes are evaluated. Now what we do, we take what's called Sentinel Nodes, which is the one main node, and there's a mechanism that done during surgery to better define these nodes, and I can get into that if you want me to. But we sample 1, 2, or 3 nodes as an indication of the entire axillary area nodes and whether the disease has spread outside the breast. What that tells us is what the stage is and also how we might treat differently. So in a way, these nodes, used to be therapeutic removal. Now it's more prognostic and predictive. So prognostic for outcome and predictive for response to particular therapy or additional therapy. So that's really why we evaluate these lymph nodes.
Does there have to be a certain number of nodes? I believe that my doctor, Dr. Oza, took 6 lymph nodes, 6. But I know some people have had 9 or 10. Does it matter on the number?
Great question. I think the whole idea is sampling, and I guess I'll get into the process. So the way these lymph nodes are selected is that actually a dye, and I wonder if that was explained to you. So basically a dye and maybe a substance that's with slightly radioactive emission is injected into the breast, the site of the tumor. And, basically then that naturally gets drained to the lymph nodes. So both the dye and the surgeon uses a kind of camera to detect emission of radiation, minor radiation, to really identify these nodes in the axilla. So sometimes they found 1, 2, 3, 4, or 5. So really, these are what they found, plus what other might palpate as well. I think generally speaking, when it's more the concept of sentinel. It's the draining, or as the name indicates, it's a primary draining node or the guarding node. If you wait long enough, that dye and that radioactivity will go to all the nodes, right? So it's really draining the primary nodes as an indication of the entire basin. So, but sometimes it goes to multiple nodes, they are detected. So that explains the higher number. I think the minimum is 1. I think in most situations I see 3 to 4, but you're right, it can be more, and it's kind of like there. The downside, obviously, is, and when you get into that, and partly why we don't remove all the lymph nodes in the axilla, is that sometimes that can cause complications related to edema in the limbs and what have you, and you might be aware of that in your education. So that's kind of, so you have to weigh this as well.
Okay. Yeah. Thank you. Have you ever tested lymph nodes having more than one type of cancer in the breast? And is that even possible?
Well, theoretically, everything is possible, right?
Yes.
I will tell you, it's very rare. I may have seen 1 or 2 situations like that, and usually these are curiosities we see. I think I might have seen and I'm trying to think, maybe it's 3 with 2 different morphologies of the tumor in the node. I've seen once a lymph node with both a metastatic breast cancer and melanoma, and breast cancer and skin squamous cell carcinoma. So from a skin cancer, another type of skin cancer, not melanoma, in an axillary node. Remember, these axillary nodes don't just drain the breast; they actually drain the entire upper limb as well. So so again, there could be a melanoma, a small tumor here in under the fingernail that would also spread to the axilla. So that's a situation where you potentially see more. I think I might have seen 1 case where there were 2 tumors in the breast and both spreading there, but again, it's very rare.
Yeah, well, this pathology testing is very important. Very, very important.
Yeah, it really is.
Yeah. What makes cancer cells invasive, fast growing?
Great question. So I think, it goes back to, how cancers develop. And it's believed that cells kind of undergo different mutations in their DNA that changes their genetic structure, okay? And, of course, most mutations that happen in cells are actually cause them to die and, selected off. But then some that are selected to be stronger continue to grow, and then they become neoplastic. When I say neoplastic, they're forming a tumor, and it could be benign at that point. But as cells continue to grow, more mutations and mutation accumulate, and cells it's self-selection, selection for the strongest. Cells that don't die off, tend to adapt better. So the way they adapt is they acquire mutations that make them grow faster, produce growth factors so that the stroma around them can help support them. So in other words, if a tumor grows continuously and there's no blood supply, it will die off, right? So tumors secrete growth factors that stimulate new blood vessels to grow and come in. So it's secretion of these growth factors around it. And then they also, also acquire additional mutation to make them divide faster, okay? So that's one aspect. How they become invasive is that they also acquire really enzymes to break the basement membrane. So cells, when they're in, epithelium, they lie on what we call a basement membrane, and there's additional tissue. So actually, cells have to secrete these enzymes that digest the basement membrane, digest the tissue around them, and then go into the wall of the blood vessel or the lymphatic space to spread elsewhere. So all of these are acquired as tumor, become more aggressive, more higher grade, then that kind of results in that.
Yeah. And you saw me smile because I'm a science buff. I love science. And so this is just right up my alley hearing all this information about it. So am I understanding that a non-invasive cancer cell can then become invasive because
That is correct.
the enzymes? Okay. So it can
Yeah.
turn itself into
And it doesn't happen in all the cases, but that's kind of like the usual progression for a lot of cancers is that way.
Okay. Are all invasive, inflammatory, and metastatic breast cancers tested for estrogen?
Yes.
Even
For
for males?
I'm sorry, even what?
And
Even
even for men?
Yes, definitely. So all breast cancers are tested for estrogen and progesterone receptor as well, because it's kind of very much related to estrogen, and also for HER2, which is another kind of like molecule on the surface, a receptor on the surface. And the reason for that is because a little bit for a prognosis standpoint, but really for prediction, because that we know, that hormone receptor positive breast cancer respond very well to anti-estrogen therapy of various forms. So that's why we want to test, and has it made a tremendous change, positive impact on treatment of breast cancer when that was first started, probably in the 70s.
In the 70s, yeah. Okay, thank you. That's interesting.
Yeah.
So I want to share something right now. Share this picture. Do you remember this?
I do.
This is when my husband Ron and I were with you in the office, and I had asked to meet with you because I wanted to see the cancer. So I had asked to meet with the pathologist, and it seemed like that was a pretty big deal. Because if I recall, you said no one had asked to meet with you before, and I thought that's strange. But I wanted to see what had tried to attach itself to my body. And so this is us meeting with you. Dr. Hameed, how does, and I know that you have some cells that you want to share, how does a healthy cell look? And is there any healthy cells on the slides that you will share about my breast cancer that everybody's going to get to take a look at, that I signed for, and it's all HIPAA compliant?
Right. So I think the quick answer, it depends on the biopsy and the tissue that's removed. In most situations, there is some healthy cells in there, and we often use them as a kind of a benchmark to compare things to, internal control if we're doing additional studies. So what they look like, I mean, I don't know, do you want to share one of your slides, or should I go ahead and show some of yours directly? What's your preference?
I'm going to allow you to do it. That'll be great. Yeah, because
Okay.
you can take us through the unhealthy cells and the ones that are cancerous and all of that.
Okay. So give me 1 second here.
That's
All
fine.
right.
I just know that this is just valuable information.
Oh,
and
yeah.
Very informative. I've had several questions throughout the week on breast cancer, and different ones asking me, do I know the definition to this or to that? And I'm like, I am not the expert. Please talk to your primary care, your oncologist, but these types of spotlights here, I'm sure will be
Very beneficial.
Yeah.
Very beneficial.
Well, that's what I hope to achieve. So let's see if I can share this. It's a bit out of focus.
Oh, good. It's not just my eyes. Oh, that looks good.
Yeah, that's an occupational hazard with us as well sometimes.
Yeah.
So what I'm sharing here, this is actually a breast duct, okay?
Okay.
Bigger duct, and it's a very low power view, and around it, these are breast lobules. Some of them are a little bit cystic, a little bit enlarged. That's all within what we'd expect in benign breast tissue. So again, you have that arrangement. These are the lobules I mentioned earlier, which if following during pregnancy, they enlarge, they become bigger and they proliferate, and then after childbirth, they actually become secretory and produce milk, and that drains through this ducts, and they go into bigger ducts, and eventually to reach the nipple. There's several larger ducts that drain different areas of the breast, and where the milk is produced. So this is kind of like a normal lobule. I can go higher a little bit to show you a little bit more of the cells. So adjusting between the microscope and the camera can sometimes take a little bit. So see, I mean, this is a lobule. One of the things about normal tissue is that it tends to form these lobules. It has kind of like an arrangement, just like you might arrange the sofa and chairs in your living room. There's a part on the coffee table and the side tables. There's an organized way normal tissue set up. Even when you look at this kind of glandular space, it's almost as much as far away as this one and this one and this one. They're kind of grouped together and they're equidistant pretty much to each other. So that's kind of like what you expect to see histology, and every organ has some kind of architecture that is preserved. And then the cells themselves, and I'll show you this cell, just this group here. So,
and these cells are dyed.
I'm sorry?
And these cells are dyed. They're not the original color like how they would be inside the body.
Correct. So that's a great question. So in order to visualize tissue, we actually stain tissues. The usual stain, what's called hematoxylin and eosin. So, and again, there's since we're talking about science, and I'll give you the science part. So hematoxylin is blue, okay? And it's acidic. I'm sorry, it's basic, and it thus binds to DNA because it's an acid, right?
Yes.
Deoxynucleic acid. So where is that located? In the nucleus, okay? Eosin, which is the pink one, is acidic, so it binds to the basic, and there's more protein, there's more ribosomes in the cytoplasm, and that's why usually you get more pink cytoplasm. That's a general rule, but that's really like kind of like the chemical basis for how we stain most of tissues. Of course, we use additional specific stains and what have you, but that is kind of like what we start up with. Every case is stained with these. Thanks for that question. I enjoyed talking about that science as well, obviously. So when you look at this lobule and looking at the cells, now, there are different patterns. I mean, this is benign and this is benign. Obviously, it looks a little bit different here than that one. But one of the things that is associated with benign cells, look at how the ratio between the nucleus and the cytoplasm. Really? It's a low, what we call nuclear to cytoplasmic ratio. Now that's one aspect. The other thing you have, again, I have to go to higher power, but smooth nuclear membrane. There are a lot of these subtle features that I can list to you, but often we, as you develop expertise in this, it becomes a pattern recognition. I don't necessarily need to look at all the details and enumerate them to tell they're benign or malignant, but it's kind of like it's a constellation of these features that happen behind in your brain. I'll give you a perfect example that a famous pathologist who teaches generation of pathologists said. I was at a conference, and somebody asked him, Dr. Rosari, why is this, why is this tumor called this? Why is it not that? Or why did you call this not that? He said, so he started responding scientifically. It's this. And the person who asked the question said, well, I still don't get it. And he goes like, listen, I know it's this because it looks like this. You know, if you ask me, you know, how do you know it's your grandmother? I know it's my grandmother. She looks like my grandmother. I can't tell you what her eye color is or describe her. She just looks like my grandmother. So I hate to oversimplify, but sometimes, you know, and you know, this happens, you know, with training and experience. That's how it happens. The other example is, I don't think Tiger Woods, before he, you know, plays, really thinks about his stance and how he's holding, you know, his driver, right? It's all intuitive, right?
Yeah.
He doesn't think about it. If I'm going through and getting golf lessons, I would really be focused on that. So that's kind of like a summary. So
just because.
yeah, I had to put that in. So this is like an example of benign. Is that good for you?
Yes.
For a baseline? So again, this is talking about epithelium. The breast has also around it what I'm pointing to, some, you know, stromal cells, fibrous tissue, but this is the epithelial elements of the breast. This here is a blood vessel, right? See the what's red is the red blood cells here. So that is kind of like the baseline, benign material. And again, I'm going back to the low power. Excuse me a second as I adjust the light. You can, again, emphasizing kind of like the lobular architecture, the duct, and how things are arranged. So when you move in, you get to here. Okay.
That looks quite different.
Yeah.
Quite different. So
That's
just
ominous.
in the interface, this is all adipose tissue. You know, the majority of the breast is supportive adipose tissue or fatty tissue. But then you get into this very blue area that looks very different. It's large, and this is something we identified grossly as a lesion, and we sampled sections accordingly. So you look higher here. I'll go to the highest power, I think, that way. So move it just a little bit. So this here, this is all, this is your breast cancer here, and which you've seen. And all of these are epithelial cells. And you look at them, we talked about like the nuclear to cytoplasmic ratio. You know, you don't see much pink. It's all blue because it's pretty much mostly nuclei and little amount of cytoplasm. It's closely packed. It's not forming any organized structures, okay? So this is an example of an invasive breast cancer. And since we talked about proliferation, this actually in the middle is what we call a mitotic figure, as is this one here and this one here, okay? Which is basically these are dividing cells. We'll visualize them in the process of dividing. And that, you know, the level of mitotic activity is one component of histologic grade for breast cancer and other cancers as well.
So Dr. Hameed, are you saying that these, and I can't pronounce that word, but these cells that you just pointed to, are these cancerous cells that are dividing?
Correct. They're cancerous cells, and we're called them, they're in the process of mitosis, M-I-T-O-S-I-S. They're dividing. Right. So they're different stages, and that's why they don't look all the same. Sometimes you actually can see, like, you know, all this is condensed chromatin material, the DNA of the cell, and sometimes you actually see in the process of separating apart into two cells, depending on when you catch it. Yeah. So again, that is one histologic feature of malignancy, and also it's used for grading. So higher grade tumors, it's a component of how we grade them.
Yes. Wow.
So how do you determine whether they're aggressive or not?
Great question. So part of it is based on the histology. So kind of, and I'm going to answer specifically to breast cancer, obviously, but this kind of applies to other cancers as well. There is a spectrum of differentiation. So when the better differentiated tumors, well differentiated, try to recapitulate the morphology of the organ where it's coming from.
Mm-hmm.
So, for example, a better differentiated breast carcinoma might try to form lobule-like structures or glandular spaces, right? And that is different from this view here, where we're really saying mostly like sheets of cells that, some of them are trying to group together, but they're not really, there's no lumen, there's no space, they're not as, so one aspect of it is, glandular or tubular formation. So that's a better differentiated tumor. Another aspect is the how fast it's growing. So that's another aspect. And then kind of like looking more at the nuclear features as well. So that kind of like defines histologic grade, and grade is related to aggressiveness. But that's only part of the story. I think what we know about a lot of what we know about tumors and how they behave, and how they relate to morphology and other features, like the hormone studies and what have you, really relate to these long studies with long-term follow-up, cancer registries that really have evaluated, okay, tumors of this specific kind, do they behave more aggressively than this specific kind, or this histologic grade behave more aggressively? So it's one thing to observe that, but I think the natural history and the follow-up based on history and what we know about these tumors really tells us that this is more likely or not to behave in a little bit more aggressive manner.
I see.
So that determines what some cancers are more curable and manageable than others.
Correct. It's multifactorial. I mean, it's the histology, it's the receptor studies you mentioned. Interestingly, I mean, there's kind of a two-edged sword in some of these cancers. So, for example, slowly growing cancers, okay, might stay for a long, long time, okay, and may not kill patients, okay. They're slowly growing. You might, the primary modality is treatment. On the other hand, faster growing tumors, okay, because they're growing fast, they're using a lot of nutrients, they're dividing fast, it's much easier to disrupt them with radiation and chemotherapy. So it's kind of, because they're growing so fast, it's easier to trip them, so to speak, right? So I think some of what cancers who might be very aggressive if you don't treat them, because they grow so, they're potentially curable, whereas others are very slow to grow, and people often die with those cancers, not because of those cancers.
Oh,
You
wow.
can't cure them.
Okay.
So it's multifactorial.
Interesting.
That's very interesting. Okay, I think you might have answered a lot of this one question I wanted to ask you, and that was how pathology studies determine the type and the aggressiveness and the stage and the metastatic condition of the various forms of cancer.
Yes, and I want to chime into that because I understand that there are negative and positive margins. I think you touched on that a little earlier of cancer cells. So please explain that, the margins, in reference to Ron's question too.
Great question. So that's something we definitely look at. Let me kind of demonstrate that on the slide. I think that would be better. So I'm going to the lowest possible power to this example of the tumor. Hold on a second.
And
So obviously, you can see kind of like the blue is all the tumor here. Actually, this area here, just as an aside with the pink area, this is where the site of the previous biopsy. So it's always good to know to see that. We look for the, they usually also leave a clip. We identify that grossly. Just we know that the area that was sampled before, we have it now. This was excised. This is an aside. So when we look around this tumor, I'm going to just look around, show around it. You see that we have a lot of adipose tissue around it. And then we get to here, this is ink, right?
Yes.
So this is margin. So let's assume black ink is the posterior margin. We can actually evaluate how far it is from here to here.
Oh, okay.
So, and really determine that margin. On the other hand, I think in your situation, the tumor was close to the opposite anterior margin. You can see some ink here. This might not be the best representative section, but it's a good example. Actually, I don't need to show you another one, but you see that almost yellowish ink here? This is actually, and so it's close here. So it was determined that this is close to the anterior margin. And often that determination can be done intraoperatively. So in your situation, the surgeon actually went back and took additional from the anterior margin because the tumor was evaluated while intraoperatively, and he could tell that, or it was possible to determine that the tumor is close to one particular margin, and thus go back and take more tissue from that margin. So obviously that's very beneficial, saves it, the need for a potential additional surgery afterwards.
Yes.
So
does that mean that margin mean that the tumor was moving where it could have metastasized?
No, it does not have to do anything with the metastasis per se, but it's kind of like if we see tumor at the edge, then or close, then there's a higher chance of recurrence at the site because we're leaving some behind. Okay. And of course, if it stays there, then there's obviously a higher chance for development of metastasis. So that's why when there is tumor that is at or close to margins, and it's a lumpectomy, not it's breast conserving surgery, then the decision is either to go back and or do additional radiation therapy to minimize these chance of local recurrence.
So then I guess that's how a surgeon can determine if all of the tumor has been removed once someone has gone through chemo and radiation.
Correct.
Okay, thank you.
So how do they determine whether or not it's better to completely remove the breast as opposed to perform a lumpectomy?
Okay, so I think there's a lot of factors into that that goes into that, and surgeons are better equipped to answer that question. But I think it has a combination of it's primarily so from an outcome perspective. Studies have shown these are randomized prospective studies. I think back in the 90s that have shown that lumpectomy plus radiation is, from an outcome perspective, from a cancer perspective, cure and follow-up, is equivalent to mastectomy. Okay, so that's from that perspective, they're equivalent. Where does it become issue? Is localized excision achievable without too much distortion to the residual breast? So factors that get into that is size and distribution of the cancer. A localized 1.5 centimeter cancer, okay, has a better prospect, just off the mill for breast conserving therapy than ductal carcinoma in situ, which we know is not invasive, but spans 5 or 6 centimeters across the breast. Does that make
Mhm.
so it has to do with all the additional other aspects of cure. And of course, patient preference is a big deal into that, plays a role into that. And I think, Mrs. Garnett, you probably, thought of all these things and weighed your decision. So you probably know about this from a personal perspective more than me. But it's really these two parameters that play a role: patient preference and outcomes, kind of like cosmetic outcomes after surgery. These are the two things that are kind of the big players.
Oh, I see. I see.
Yeah. I know last month I interviewed with Dr. Stephanie Graft, the oncologist of Sarah Cannon, who you know very well. And Dr. Graft spoke of genetics, and then it's a genomics.
Genomics.
Genomics, thank you. Genomic testing. Is it necessary for every post and current cancer patient to have this test, the what is it?
Genomic testing. The quick answer is no, not every patient, but I think it always, I think the question always has to be asked whether it needs to be done or not. Okay. So there are genetic tests that are specific to the tumor, okay, that might need to be done, and sometimes that's necessary for diagnosis. So there are certain tumors that, so to speak, have specific genetic signatures that tells us, like what the type and how they might behave and what have you. So these are things we almost have to do. So that's one aspect on the tumor testing. There's also molecular genetic tests that might guide therapy for particular tumors. But I think what you're more asking about, if somebody has a tumor, do they need to be tested to determine if they have this tumor is secondary to a familiar increased risk of cancer, correct?
Yes.
So these are tumors where you want to make sure, is it part of a family risk of cancer or predisposition or sporadic? And that kind of testing usually comes into play. There are certain parameters that come into play. Since we know that breast cancer is common and in postmenopausal women, so a lady that comes in with a first diagnosis of postmenopausal breast cancer probably doesn't need to undergo genetic testing to determine if that's familial. On the other hand, if she has her mother had breast cancer also, or her sister also had breast cancer, these raise indicate that may be a higher risk for genetic predisposition. So that would be a situation you would test. And the advantage is also kind of like this: offsprings and other siblings determine the risk for everyone. So that's kind of like to help better detect risk of this being familial and thus affecting other members of the family.
Yeah, I'm gonna throw in a question real quick that I have been asked several times, and then I had a little bit of a concern on just a part of it. So we all know that the COVID vaccines are out, and several individuals that are post-cancer, current cancer were concerned, as well as myself, should I get the vaccine? Now, others have had the concern that the vaccine is going to change their genetics, and especially in the Black, brown community. That wasn't so much my concern other than the effects, reactions that I could get from the vaccine. So from your opinion, would the vaccines change anyone's genetics?
No, definitely not. An emphatic no. Has no impact on genetic makeup for sure. That being said, I think, I understand, I have to, understand that people might have fears and concerns. It's something new. And there's definitely there's a perception that it might not have been tested as adequately as usual for other vaccines. And I think from a time perspective, obviously the time frame these vaccines were rolled out is much shorter and expanded. That being said, I think all the boxes have been checked from a clinical trial perspective and what needs to be done to ensure safety. I think what the way when I talk about this with different folks, the argument, well, we don't have long-term safety efficacy for the vaccines. That's true, but we also don't have long-term outcomes for COVID either. We know the short term, it can kill you in a significant proportion. It can make you very sick in a significant proportion, and the vaccines do neither. So I think that's kind of like my approach to that. And as to patients specifically with cancer, I think most cancers and most therapies related to cancer don't negatively impact our immune system, which means that we can the vaccine will help us mount an effective immune response that can protect us from getting the infection. So I think it's always a good question for an individual basis to ask your physician, can I take the vaccine? Would that impact my cancer? I think I would say probably in the 99% of patients, it would have no impact. But again, I think asking your physician directly, because there could be certain cancers and therapies that might impact it. And really the impact is that it won't be effective. Pretty much. No, it's not like it will do something adverse. I think the main concern, and my mother has yet to take the vaccine, and she is 78, correct? Yeah, 78. And because she has a history of severe allergic reactions. So that's something that has been demonstrated, and she doesn't have a lot of contact and what have you. So there are things like that might be careful. And again, that is not an absolute contraindication. It's something that one has to be careful about and what have you. So because her risk of exposure is limited, she chose, well, why go through that? And I think that's and she is a breast cancer survivor and has also a chronic leukemia. So, so, and again, she didn't take it because she hasn't taken it yet, not because of those, but rather because of her history of severe allergic reaction.
Right.
So again, this is an individual situation, and everyone has their individual things. But the quick answer, if somebody has, I think there's no reason not to take the vaccine, and specifically, there's no reason for almost the vast majority of cancers not to take the vaccine.
Thank you for sharing the slides. It's enlightened me and even gave a little bit more information that I didn't or don't recall from the first time, because I know the first time you gave a huge slew of information to us, and I know this is helpful. I know that we have a few more questions, and then we'll be done. Did you have anything else to say in reference to the slides?
No, I think I was going to say that I think every time you said that, cells talk to me and, talk to me, slides do talk. And I think that's part of the reason. Every time one looks at material, I think it's like reading a book a second time or seeing a movie a second time. I think there's always information that one can infer from looking at, pathologic material. And I was happy to share that.
Thank you so much.
So what kind of advancements would you say in pathology over the past 10 years have benefited breast cancer treatment primarily?
That's a great question. I think really we've seen a lot of advancement in personalized medicine. And of course, that's a kind of a big term, and people might understand it differently. But I think before it used to be, my mother is a pathologist. She retired several years ago, and when her reports, when she was working in the 70s, says breast invasive cancer. That's it. okay? Maybe with the size, okay? That's all we need to know. And everybody is kind of like treated the same. Do they have positive nodes, not negative nodes, and what have you? We have evolved so much, and we're getting into much more specific details that are customized for each individual patient, which obviously more detailed pathologic aspects, the histologic type, the histologic grade, margin status, lymph node status, and what have you. We also talked about the estrogen and progesterone receptor studies. So really, the biggest advances in cancer overall, and also in breast cancer, has been kind of like this move to more, personalized approach, and really identify the, specific histologic, molecular, and other aspects of the tumor that are particular to that particular patient, and how he or she would be treated. And again, it also ties into, other conditions, right? So, we talked about breast conservation therapy versus mastectomy. Before, everybody gets a mastectomy, period, right? Now, it's other aspect and patient preference that play a role in that. So it all, I think we've really seen significant advances in more personalized approaches, and that's both from a, things we evaluate and targets, and specific subtypes of tumor, and how we manage as well, and putting it all together. Again, I go back, it's being more really surrounding all the patient, and how that we can personalize their management to their specific cancer type and their specific needs.
Okay. So what ways have pathology studies been able to determine the difference between Caucasians and people of color regarding the frequency of certain types of cancer, and the aggressiveness, and also the survivability of certain cancers?
Yes, I think that's a great question. I mentioned earlier the cancer registries and the databases. These have really helped shed a lot of light on differences, and racial differences between different types of cancer, whether it's incidence and survival. So that's, a lot of these really are based on pathology studies, right? As I mentioned to earlier. Okay, I characterize this tumor as no special type, or I mentioned the type that occurs only in women, the lobular type, that carries different connotations. And again, looking at the prevalence and outcome in different populations, that can help shed light. The grade, histologic grade. So a lot of these studies really has helped showed us, coming into the door, that unfortunately, some breast cancers present at, a bit more aggressive, which is inherent to the tumor, aggressive histologic types, or molecular subtypes of breast cancer occur in the Black community. Sometimes, there's also people presenting at a little bit more advanced stage, and that also ties into potentially health disparities and access to healthcare, and we know that is a big issue that we have to deal with. So a lot of that really stems, relates to all this pathological identification and kind of comparing these different populations.
Oh, okay. Have there been any forms of cancer that have been totally eradicated, or at least become less pervasive?
Yes, I think we can. I think the biggest one out there would be cervical cancer. So, when you think, it hasn't been eradicated, but I think kind of like with discovery of, with the advent of cervical Pap screening for Pap for cervical cancer, this has made probably the most significant impact in the incidence of breast cancer, of gynecological cancer in the last 50 years. Okay, so just that screening tool, because it's so effective, and so this has resulted in a significant reduction of the incidence and prevalence of cervical cancer, and much earlier presentation. So that's one thing that has
Right.
really changed. Now that is not all across the same, and again, you get into different populations and across the world, and it's not necessarily the same. So that's one thing. The other thing I alluded to is rapidly growing tumors
Mhm.
that can respond very well to chemotherapy.
Mhm.
So certain type of leukemias and lymphomas, especially in children,
Hmm.
okay, they can be cured now. These were always fatal,
Wow.
okay. So a lot of these are curable.
Wow.
The other one is testicular cancer.
Hmm.
Testicular cancer also grows very quickly, but it's one of the earliest solid tumors that showed a very good response to
Wow.
chemotherapy and radiation. So these are all examples of tumor where the really kind of advances have really helped reduce rates. And there are many, many more, and some also related to particular genetic abnormalities specific to a particular tumor and how we treat them. So we
It's
know
great to hear.
that.
Yeah, it really is. It really is.
So I think it's really been great. Of course, the path forward still remains. There's still a lot of cancers we want to do
Yes.
better at,
Yeah.
for sure.
Yes.
Most definitely.
Yes. Why do you think it's important that the general public learn more about cancer and cancer treatment?
Mhm.
That's a great question, and I think and again, you guys can probably answer it better than me because I'm going to kind of preach, but you're going to preach to the choir, right? So I think for all the reasons we discussed, I mean, it primarily boils down to cancer is one of the leading causes of death across the world, not just in the U.S. It's very significant, and I think there's always a kind of fear and apprehension and a lack of understanding about cancer that can compromise how we deal with it and how we approach new development of new symptoms and how to kind of be on the lookout for potential cancer. I think we're kind of like we're afraid of it. We don't want to know about it, so we want to avoid it.
Right.
And not talking about, not learning about it helps. So I think that's the big reason why we do need to learn about it. I mean, everybody knows about maybe I don't know, diabetes, for example.
Yes.
But there are more cancer patients than diabetic patients. Right?
Right.
And of course, it's you can argue there's a lot of different types of cancer, but I think that's why we need to definitely learn more about it. And it's something I think probably talk to folks. I would bet 99% of people have someone in their family or they know that has cancer or will get cancer in their lifetime. So, and it's just it's part of life, right? I mean, I think it's just the better we understand things, the better we can deal with them.
That's so true.
Very true. Very true. Very true.
Well, unfortunately, this is the final question for today. Dr. Hameed, what information would you like to leave as far as additional resources, different additional information leading to cancer? What information would you like to leave with our listening audience today?
Yes, so I thought of that, and a couple of things is, know your pathology. So if you are dealing with cancer and if in a situation where you're dealing with cancer yourself or in a loved one, I think really try to understand your pathology. Ask for your pathology report. Make sure you understand different aspects of it. And then I think a lot of people ask, it's very common to look for second opinions. I think it's not unreasonable to evaluate if there's a need and get a second opinion, confirm the malignancy, because like I said, it is something that it's going to determine all the subsequent treatment. And in fact, a lot of places have mechanisms in place that review the pathology. And as you know, you had your biopsy and surgery in one location, and when you went to another location, we reviewed the pathology, and that's how you became my patient. So, and we confirmed everything. So I think that is one thing to keep in mind. And just remember, we're part of your medical team. We work silently behind the scenes, and but we're always there, and we're always available to discuss your pathology, review it, and help you understand your disease.
That's really good to know. I think it's important that everybody know that.
Yes. I thank you so very much. I thank you so much. You said a part of the Gwinnett Cancer Society nonprofit statement, your pathology matters.
Right.
Your pathology matters. So thank you so much. Hey, audience, you just heard from Dr. Omar Hameed. He is the Division Medical Director for the Health Corporation of America Midwest Division in Kansas City, where he oversees pathology and laboratory services. Thank you so very much.
Thank you. Thank you. I wish you a great day.
Thank
All
you.
right.
Thank you. I appreciate you.
We do.